Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities: the Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community. Hello, everyone. I'm Doug Maynard, an Associate Director at Children's Healthcare Canada. And as this is our first webinar of the year, I'll start by wishing everyone a Happy New Year and welcome everyone to a new year of Spark Live, our webinar series, where we curate, convene, and showcase excellence and innovation from across the child and youth healthcare community to spark conversation, ideas, and action. I'd also like to mention, as you know, as some of you may or may not recall, back in October, we did change our name from CAFC to Children's Healthcare Canada. And among the many other changes over the last few months, we have updated our website at childrenshealthcarecanada.ca, just launched today with a new look. So please have a look at it. And if you find anything that's not working, or if anything you like, don't like, whatever, any feedback that you have for us on the new website, please don't hesitate to let us know. All right, so on with our presentation. And since we are live, I do want to remind everyone that you do have the opportunity to type questions into the question box at any time, questions and or comments. We will check for questions throughout the session, but please don't feel you need to wait until the end of the presentation before you type the questions in. Go ahead and put them in as you think of them. And also feel free to share your thoughts on Twitter and be sure to tag us at Child Health Can. All right, so today we are talking about Parents Empowering Neurodiverse Kids, the Strongest Families Neurodevelopmental Program to help parents manage challenging behaviors. And today's webinar is brought to you in partnership with our friends at ChildBright. And ChildBright is the strategy for patient-oriented research that aims to improve life outcomes for children with brain-based developmental disabilities and their families. And it's our pleasure to work with ChildBright over the last couple of years and over the next few years to bring lots of their exciting work to our webinar program. So it's a real pleasure to showcase some of that excellent work that they've been doing. All right, so today it's now my pleasure to introduce our speakers today. We have 4 speakers from the Strongest Families program that's part of the ChildBright Research Initiative. We have Dr. Patrick McGrath, who's a clinical psychologist, scientist, senior health administrator, and social entrepreneur. He's a professor of psychiatry, pediatrics, and community health and epidemiology at Dalhousie University and is a scientist at the IWK Health Centre in Halifax, Nova Scotia. We also have Dr. Lucy Locke, who is an associate professor in the School of Social Work and an associate member of the Departments of Pediatrics, Neurology, and Neurosurgery at the Faculty of Medicine at McGill University in Montreal, Quebec. We also have with us Donna Thompson, who's the author of a couple of books, The 4 Walls of My Freedom, Lessons I've Learned from a Life of Caregiving, and The Unexpected Journey of Caring, The Transformation of Loved One to Caregiver. Donna is also the senior family advisor on the ChildBright SPORE and a co-researcher on the Strongest Families Research Project team. And she's also on the board of directors of the Kids Brain Health Network. And finally, we have Karen Turner with us, and Karen is a research coordinator at the Center for Research in Family Health at the IWK Health Center. And Karen has been part of the working with the Strongest Families Institute in modifying this program to ensure its relevance to families of children with neurodevelopmental disabilities. So without any further ado, it's my pleasure to hand the podium over to our presenters, starting with Dr. Pat McGrath.
Well, thank you very much for the opportunity to speak today. I just wanted you to be aware of our conflicts of interest, which are on the slide right now. And if there's any other information that you need, please feel free to ask it. What I want to talk about is this journey from science into practice or research into care. And it's often phrased in terms of valleys of death, not to intimidate anybody, but that's the way the literature says. It's very hard to move something from basic biomedical research into clinical science and knowledge, and that's usually referred to as Valley 1. But less well known is Valley 2, which is moving clinical science into health decision-making and clinical practice. And that's really where we're working, where we're trying to move information and ideas and knowledge from the clinical realm right into practice, from clinical science realm right into practice. And we're doing that with pragmatic clinical trials that replicate what happens in the real world. The Strongest Families Institute is the vehicle that we use for dissemination of these programs. And just to tell you a little bit about that, it's a federally incorporated not-for-profit that has a volunteer board of directors. We have about 75 employees, mostly in Halifax. We deliver care, and I say we because, as you know from the conflict of interest, I'm the chairman of the board there. We deliver care, we participate in research, and services are sold to government and other agencies in different provinces, military. Some are actually funded by foundations. Bell Let's Talk has been very generous in funding us in English and French, and we serve 5,000 to 6,000 families a year, and that's growing all the time. The other agency or organization that's important to understand is the Center for Research in Family Health, and that's our research group here at the IWK Health Center. We're funded by grants. We do research.
I can pick it up if that's right. So these are the 4 guiding principles that are embedded in Strongest Families programs. They aim to have the interventions that they deliver to be effective, efficient, child and family centered, as well as safe and accessible. One can go on and on, I guess, about what other kinds of principles guide their work, but for them, I think these are the ones that are regarded as most important. All right, so their approach is to work with families as partners who are experts on their families. It's very much a strengths-based approach, and the staff that they have are trained. They're trained extremely well. Dr. Patricia Langley-Potty oversees their training and provides ongoing support. There's a no waitlist policy. The protocols are evidence-driven, and they use analytics to evaluate outcomes on an ongoing basis with every family. The intervention is viewed as education. It's not therapy per se. So they're not using therapists to provide support to these families, but rather coaches, where there's no stigma to learning skills from a golf pro, a personal trainer, or a swim coach. This approach is scalable to the health system and is approached as being scalable right from the very beginning.
We're back.
Apologies for stepping out there.
All right. Is there anything you wanted to add to that in terms of the slide that we're on right now, Pat?
Yeah, I'll go to the next slide. Okay, if you can move to the next slide. So the paraprofessional coaches receive ongoing training, start with background reading, learning scripts and parent handbooks. They have a bi-weekly coaches corner, and we certify our coaches as being competent, and they're constantly reviewed to see if they are competent. All calls are recorded, of course, with everybody's knowledge and permission. At the beginning, we have fairly dense monitoring, and we fade to episodic quality assessment. The coaches are highly productive and efficient. They see 35 cases in one-to-one or 90 to 100 families per year, and 200 or more a year with group-based coaching.
All right, so this is where I come in. I'm going to be speaking to you about why we've gone about developing a parenting program for parents of children with neurodevelopmental disorders. In other words, what kind of a problem, and is there a problem that this program is solving or addressing? Next slide, please. So our approach to thinking about the design of this program is what's called non-categorical. Earlier, we heard about ChildBright being an enterprise that is focused on providing support and interventions, testing various interventions for families of children with brain-based developmental disorders. So instead of developing interventions specifically for kids with cerebral palsy or kids with autism or kids with epilepsy, there is, as much as possible, a desire to develop approaches across diagnostic groups. And that's what's really meant by non-categorical. There was a definition that was developed through a consensus building process in the UK by Chris Morris, where the term neurodisability was defined as a group of congenital or acquired long-term conditions that are attributed to impairment of the brain and or neuromuscular system and create functional limitations. A specific diagnosis may not be identified. Conditions may vary over time. They may occur alone or in combination and include a broad range of severity and complexity. The impact could include difficulties with movement, cognition, hearing and vision, communication, emotion, and behavior. And really the advantage of using this kind of an approach is it's quite inclusive. It doesn't focus just on kids with a particular diagnosis that's more or better funded than other diagnoses. As we know, there are differences, and it would provide an opportunity for children who have more rare neurological conditions to be included. Next slide, please. So we've been looking and studying what the prevalence of children with neurodisabilities or neurodevelopmental disorders is in Canada. And so these are fairly robust figures. The first figure is from a data set in British Columbia, where we found that 1 in every 12 children, or 8.3% of all children, I think it's between the ages 4 and 11, have a neurodisability of some sort. And this is fairly consistent with what we found in using another population-based data set here in Canada, the National Longitudinal Survey of Children and Youth, where we found that 1 in every 11 children have some sort of brain-based developmental disorder. And then when you look within that group of kids with brain-based developmental disorders, we found that 36% have some kind of an externalizing behavior problem. That'll vary considerably from study to study and from data set, but I think that some have found the rates to be as high as 60%, but in a population-based data set, we found it's 36%. Next slide, please. One of the other things that we've looked at in our research and that my team and I have done is what does parenting look like in these families? Again, using this population-based data set, we examined how consistent parents thought their behavior was if their child had a neurodevelopmental disorder. That's the second bar that you see there. If their child had an externalizing behavior problem, and if their child had both a neurodevelopmental disorder and an externalizing behavior problem. And that first purple line is parents of kids who don't have any of these disorders. So we call that group neither. Where higher scores mean that parents think their parenting level is more consistent. So as you can see, these aren't huge differences, but they are statistically significant differences where the neither group, those parents feel that they are the most consistent in their behavior, and gradually decreasing in consistency are parents with kids with neurodevelopmental disorders, externalizing behavior problems, and then both. So these would be, they would be responding to questions like, when you give your child a command or order to do something, what proportion of the time do you make sure that he or she does it? Next slide, please. So this slide describes how positive parents think their interactions are, where higher scores again mean that parents feel that their interactions are most positive. And we see a similar pattern of, the parents who don't have a child with a neurodevelopmental disorder describe their parenting behaviors and interactions as most positive and gradually decreasing to those with both. These are, again, I would stress that these are statistically significant differences, particularly between the neither and both group, but they're not huge differences. And again, they would be responding to questions like, how often do you praise your child by saying something like, good for you, or what a nice thing you did, or how often do you and your child laugh together? Next slide. So the most robust finding that we had in our analysis regarding parenting, and robust, I suppose maybe is the wrong word, most significant finding was in how ineffective parents feel. So higher scores mean that their parents have a higher degree of ineffectiveness. So we see a very opposite pattern here, where parents who have children with no neurodevelopmental disorder, they feel the least ineffective. And those who have children with both neurodevelopmental disorder and externalizing behavior problems feel most ineffective. So they would be responding to questions such as, how often do you get annoyed with your child for saying or doing something that he or she is not supposed to do? How often do you feel you're having problems managing him or her in general? How often when you discipline him or her, does your child ignore the consequence? Next slide, please. So I think before we go into this slide, I think what that research is suggesting is that parents of kids with neurodevelopmental disorders or neurodisabilities are grappling or struggling more so than parents who don't have children with neurodevelopmental disorders with their parenting behavior, with how consistent they should be, how positive they feel their interactions are, and how effective they are in their parenting. So that begins to build a rationale for why we need a program like this. We also, and other reasons for this kind of program has to do with the difficulty in finding services for families of kids with neurodevelopmental disorders. Families are often ping-ponged between mental health services and pediatrics or developmental services, who themselves operate in silos, but mental health services sometimes don't feel well equipped to use their approaches with kids who have brain-based developmental problems. And similarly, pediatricians or neurologists might say, okay, let's have mental health see them. So there are a dearth of issues, and this was certainly validated in some key informant interviews that we did across Canada. There are wait lists for accessing these kinds of supports, and we also know that the average number of sessions in general in mental health counseling is low. I think the average number of sessions attended are 3, and even when people do attend, sometimes they don't show, or there are high dropout rates. And that may have something to do with the fact that services tend to operate using very traditional hours of operation. It's more difficult for families living in more remote areas to access also supports that are outside of the key urban centers. And even when approaches are used in mental health, the uptake of evidence-based approaches isn't that great still yet. Next slide, please. Okay, Donna, this is for you and I.
Yeah, thank you very much. So I became involved with this research project, I guess, because I was involved in Child Bright from the very beginning. I'm particularly interested in this project because it promises impact, I feel, on a pretty short timeline. I became involved in research generally for a number of reasons that I think may be common to other families who either wish to partner on research projects or participate in them. And so I think primarily I was interested in using the lived experience of my family to help other families. Just generally, I wanted to try to make the path easier for new families coming down the road, raising their children with developmental disabilities. So my own experience, our son is now 30 years old, and he has very severe cerebral palsy and is medically complex. But of course, he's had a lot of medical interventions, many of which have been painful. And for him, a lot of his own behaviors and managing his emotions were related to his hospital experiences. So, managing emotions, generally speaking, in parenting children with disabilities is just a huge part of trying to manage and cope and be resilient and be well in the context of families and communities. So that's one of the reasons that I became involved. And I guess the other reason is, something that maybe you as clinicians or other parents may not think about as a first reason. But the more I talk to families, I'm finding this is actually quite common. So one of the things I noticed just by reading my news feeds every day is I became quite worried and alarmed, as many of us are, I think, about the erosion of truth and evidence with the rise of populism, with the rise of sort of pseudoscience. What is true and what is evidence is a very powerful motivator for me to contribute to ensuring that research is based in the truth of lived experience, and that informed research is then the basis of evidence-based treatment. So I really wanted to throw my weight behind that. And I think in terms of what do I think are the benefits to families of taking part in research? It's interesting at Strongest Families, and I'll ask Lucy and Pat to chime in here in a minute, and Karen. We did we had other people do a really fantastic piece of research into the family engagement on this particular research project. And the families in our parent family advisory group were very clear in that they felt that they were able to make a strong and meaningful contribution that resonated with their family, that their personal lived experience and their child's lived experience was validated and important and helpful to the other families and the caring community of parents raising children with disabilities generally. So it's a validating, sometimes we feel invisible, sometimes we feel unimportant, we feel marginalized, but in a research environment, we feel that we can contribute, and we feel that our experience suddenly has very strong meaning, and people are really interested in hearing our stories. So that's very empowering in itself. Do you have anything to add, Lucy, about what benefits you think there are to families? Am I missing anything that Megan Aston and her team captured?
I think one of the other things that has happened for the families that have been participating in our program and the development of the program, and ultimately in its implementation, is that they've made a connection to one another.
Yes.
And maybe you can speak to that as well, Donna.
Yeah, we have a very strong and bonded community of families who are all partnering on this research project. But I think it's possible to build community with families who are participating as subjects in a research project too. One of the facets of this particular project, and again, Pat and Lucy can speak to this, is a Facebook group in which families can exchange experiences and ideas and information and support. And all of these families will be participating in the research project itself. So at every level, there's building community built in, hardwired into this research project, which is completely fantastic because together we are stronger. That's definitely for sure. And I'm just going to put it right over to you, Lucy, Pat, Karen. In what ways do you think parents have informed and shaped this program and this study?
Well, maybe I can say a word. It's Pat McGraw here. We've always used parental involvement in strongest families for probably for the last 10 years. But this time, because of the encouragement of the SCORE, because of Karen's work and the commitment of the investigators, we did it much, much more. And we found that it gave us a much better idea of how to package, how to move, what to do, even the specific interventions that we've chosen in terms of, as you were mentioning, in this 3-armed pragmatic trial, one of the arms has a very strong component of parent to parent. And that was, we had the idea, maybe we should try this, but it was the parents who in a very articulate way, a very reasoned way, were able to explain to us why that was important and why it might be very effective. So I think that they influence certainly the what the program looks like, the examples, but they also influence the actual interventions. And they had a major impact on our measures, in which we selected measures. We certainly did that from a research perspective, but also in terms of the measures that were didn't feel like a violation and where it felt like they were affirming the parents, was a point of view that we couldn't get except by their involvement.
Yeah, I would add to that the process around measurement selection was really interesting. And I would say that there are probably measures that we're using in this study that would not have been there otherwise if we had not spoken to the parents. As an example, because we asked the parents, if you participated in this kind of a program, what do you think would change for you and for your child? And one of the ideas, or one of the concepts that they came up with, or responses that they came up with, was hope. They felt that they would feel more hopeful. And so we went about looking for a measure of hope, and we found some, and we presented these measures to you and said, which one makes sense? And as a result, that measure has been included in a package of, amongst others. But yes, I would say, and Karen, you might have something to add about the because you're often interacting with parents on Facebook about the actual details of the interventions themselves.
Right. I agree with you. The thing that really stands out with the measures is adding that measure of hope. That was really important to the parents. Their support for the parent-to-parent connections piece was really intense, and it led to us incorporating that, as Pat and you have said, into the program. But our parents have been involved in every step of this research project from the beginning. So they've read our content, they've provided feedback, we've sent it back to them again. They've been very heavily involved and committed to providing as much feedback as they can and when they can. We have a number of parents on our committee, about 14, and their role is to just contribute, when it's convenient for them. But we've had a really supportive group all along. And the other thing that they've been doing really well, it's really important for us, is for them to comment on our animation as we've been developing our animated videos, both in the scenarios that we chose to portray, which would be challenging for many parents, but parents of kids with neurodevelopmental disabilities really weighed in on what were the things that were common and that they needed help with. So everything from the movements of children with disabilities to the scenarios, they've really had a big impact on.
Mm-hmm. Thank you, everyone, for weighing in on that. I think the next question about what can clinicians and practitioners take away from parent engagement and research. I think what I'll just begin by saying what I believe as a parent, clinicians and practitioners might take away. I think, the examples that Karen and Pat and Lucy just gave sort of illustrate that, first of all, families engaged in this project, we all felt at the very beginning that we wouldn't have very much to offer. Oh dear, sorry. We felt that we wouldn't have much to offer. We were a little bit nervous of weighing in at the very beginning, but once we did, and we were encouraged in a very friendly and supportive way. I can't stress that friendliness in research is just the basis of trust building. Everybody on this project was so friendly and kind, and gave us the support that we needed to be revealing and to be good partners and effective partners on this program. But I do think that what it revealed to me is that clinicians and researchers and practitioners are not always aware of some of the nuances of the lived experience. For example, in the some of the measures that we looked at, a lot of people said, "Oh, this is so depressing. There are so many negative questions here. I feel hollowed out. I feel, diminished after going through these 150 questions about how poorly my child and family are doing." We wanted a bit more balance of looking at the strengths. One of the reasons that many of us joined this project is because it's called Strongest Families, and the inference being that I can be a strong parent. And so I think that element of hope, that element of resilience and competence, and working together in a friendly, collaborative way to achieve those elements in this project is where the learning has occurred. But again, Lucy, Pat, and Karen, I would ask you if you have anything to add to that.
Yeah, I guess when we came up with this question, it was because of our audience, and we were really wondering what the takeaway would be for them. And I mean, I don't know. I'd be really interested in hearing from the audience about that. But I can give you another example of some practitioners that I've been working with who have participated in an advisory way and some research and there's a parent component and a professional component to the advisory group. And we asked parents about what they needed at different stages in a child's development, at the time of diagnosis, at the time of school entry into high school. And we've come up with the top 10 needs. And the managers and directors of services have been really listening to what parents are saying that they need. And they're really starting to think about how they can redesign and redeploy resources in different directions based on what parents have said that they need. And this, to me, has been a fabulous experience and an example of how parent voices can can inform how programs are delivered and services and supports are delivered.
Mm-hmm. And I wondered here, Pat, do you want to say something about the PTSD extension?
Yeah, we're going to be doing a PTSD extension, but I think we should get on to the rest of the presentation because we're at about 40 minutes.
Okay.
Next slide.
So next slide.
Next slide. Thank you. Thank you, everyone. Okay, so the end result of all of this collaboration between parents and researchers that we've been talking about, we have the new Strongest Families program, which is called Parents Empowering Neurodiverse Kids, which our parents, of course, helped us come up with. So the basic format of the this new Strongest Families program is the same as the original program in that it is delivered over the internet online with the help of a telephone coach. The program skills are also the same. There are 11 sessions, each teaching different skill to the parents. But they've been updated to provide information that's more specific to families with kids with neurodevelopmental disabilities. So we've added, as I mentioned before, the skill demonstration videos have been animated, and the content of those has been changed so that the scenarios resonate more with families of kids with disabilities. And then we're also going to offer this program in two different formats. One will be group telephone coaching, and the other one is going to be self-managed, where the parents will go through the program online on their own. So this, as we mentioned earlier, this self-managed piece is brand new, and it's going to be supported by this parent-to-parent connections, this community that we're going to provide through Facebook. We will have two groups, one for the parents who are in the group telephone coaching program, and a separate one for the self-managed program. Each of those Facebook groups will be led by a parent who is also a parent of a child with neurodevelopmental disabilities who has some savvy in the Facebook world or the online support group world. And they will help to encourage our parents to be active in those online communities so that they can support one another as they go through the program skills, but also to share whatever information they think is important to them. I think that's really going to evolve with the group. We don't really have too many preconceived notions about what's going to happen in those groups. But the basic idea is that they're there to support each other. The parent facilitators will prompt them to reflect on their experiences with the program and the skills as they are learning them and practicing them, and help them get through any kind of sticky problem areas that they find they're having. The other thing that's brand new is that we always provide a resource page to Strongest Families, but this time we are connecting to an existing website that's called the Childhood Disability Link. This is a website that was developed at McGill University, and we've had a part in expanding this website by providing information on Canada-wide respite services and financial supports for parents. So that was a really important addition to this website, and we'll be providing that to each of the parents who are in the program, and also the ones, who are in the study who get into the information group. I'll explain that a little bit more later. Next slide, please. So this is just a list of the Strongest Families core skills that are taught. And as I said, they're the same as the standard program. It's just that we've really customized them so that they are more specific to the needs of the parents of kids with neurodevelopmental disabilities. Next slide. So what's next? Now that we've created the program, of course, we have to test the effectiveness of it. So within the next few weeks, we plan to start to recruit families from across Canada to take part in a randomized trial. So we're going to compare the two versions of the Strongest Families program, that is the group coaching and the self-managed. We're going to compare those to the information group, which is our control group. So you can see here the components of each of those arms of our three-arm trial. Both groups, intervention groups, will get the online parenting program. One group will get telephone coaching, and both groups will get the parent-to-parent connections. All three will have access to the resource page. And then it's very important to note that the families who get randomized into the information group will not receive the program right away, but at the end of the study, which is 10 months period, they will receive access to the self-managed materials and also to that parent-to-parent connections group. And by the way, the parent-to-parent connections group will stay open to all of the parents who have been assigned to those to the Facebook group for as long as the trial is taking place. At a minimum, we're not sure how long that will be able to sustain itself, but they will always have access to that as long as it's open. So we're also looking for 450 families to take part in the study. So you can go to the next slide and I'll let you know how people can get involved. So we are looking at enrolling parents. It's a parenting program, so we don't ever talk to the child as part of the intervention. So here I've listed the characteristics of the child, though. We're looking for parents of kids between the ages of 13 and 14 who have been diagnosed with a neurodevelopmental disability, such as autism, Down syndrome, epilepsy. There's a list there that you can see. And it's not limited to these more, prevalent conditions, but other more rare brain-based developmental disorders will be accepted as well. The child has to have mild to moderate disruptive behavior for at least the last 6 months, and those are disruptive behaviors that are interfering with their tasks of daily living, as reported by the parents. And the child has to have the capacity to understand everyday language and instructions and to be able to communicate their needs. So we're using that to evaluate, whether or not the child can understand one-step instructions. They have to be able to do that to take part, to benefit from the parenting program as the parents deliver it. As far as the parent or the primary caregiver, they need to be able to read, write, and understand English. They have to have access to a telephone or computer, phone or tablet that's connected to high-speed internet. That's very important. They need to be willing to have a Facebook account during the study period, and that is for the purpose of accessing that private, closed parent-to-parent support group on Facebook. They need to be able to commit to the demands of the study. This is also really important because we need to make sure that parents understand what the time commitment for what they're about to embark on. So they have to be able to, at a minimum, be able to meet weekly at the same time to take part in those telephone conversations, support groups, and that they need to be able to understand that there's a certain amount of time each week that's going to be dedicated to online self-study, as well as the group coaching and then practicing the skills as well. They have to be able to spend at least 3 days a week in face-to-face contact or by telephone or video chat with their child. So that's just to ensure that if children are in a situation where they go between homes, that at least we have a minimum number of hours and contact that the parent has with the child to be able to implement the program and practice the skills. Next slide. Who cannot take part in the study? Of course, we always have to be careful about safety issues and whether or not taking part in a trial is appropriate for a family. So if the child is at risk of serious harm to themselves or other, that would be an exclusion. If they've had a suicide attempt within the last 6 months for similar reasons, that would be an exclusion. Moderate to severe self-injurious behavior in the child, for example, banging their head or biting themselves or scratching themselves, to a moderate or severe degree, the program is not set up to deal with behaviors that severe, so we would have to exclude children who fall into that category as well, and that will be reported by the parent at the screening process at the beginning. Either the parent or child has symptoms of psychosis, schizophrenia, bipolar disorder, or a major depressive disorder that is not well managed. So if they're struggling daily with symptoms of a major mental health disorder, then it would not be appropriate to enroll that family into the study as well. So that would be an exclusion. If the parent has taken part in a parent training program similar to Strongest Families within the past 6 months, that would also be an exclusion. So having said all that, the recruitment will be going on for some period of time, of course. And if a person's situation changes over time, a month or 2 or 6 months, they can always reapply to the study again. Next slide, please. Okay, the moment you've all been waiting for, how to apply to the study. Every person who applies to our study or is interested in taking part will apply through mystudies.ca. There will be that's our screening and consent web platform. Every person, all of our media and all of our recruitment materials will have the address for mystudies.ca, and then the person will just go and apply themselves. We have a telephone number, a toll-free number that's there. We have easy access to an email to contact study staff if people need help, and we have a contact button on every page. So they can download their consent form there and keep it for their records. And if anybody needs help getting through that, of course, we're here to help them with the screening and the consent process. If you are a clinician or a service provider and you'd like to refer other people to the studies, the best thing to do is direct them to mystudies.ca. We have posters and brochures that are available both electronically and paper format. We're more than happy to mail those to you, as many as you need. And you're free to distribute those through social media or any other avenues that you have to connect with families who may be interested and could benefit from this research project. We have a study recruitment network sign-up sheet. I don't know okay, it looks like that's been sent out to families or to the audience. If you'd like to receive recruitment information, so we're not quite ready to start our recruitment for the study yet, but we will be within the next few weeks. The best way for you to be informed about that is to just enter your information, your email. We ask a few short questions about what your role is. That's optional as long as we have your email address, and we'll send out information about when we start to recruit and how is the best way for us to either provide you with posters and brochures or anything that you need to help facilitate you communicating about the study to the clients and the patients and families that you work with. You tell us what you need and we will be there to help you for sure. One important thing that we'd like to draw your attention to is that ethics review is not needed for individual institutions. This is something that we talk about from time to time, and everyone seems to have a different kind of different policies for their institutions. But we consulted with the Secretariat on Responsible Conduct of Research for the Government of Canada, and we were assured that if the person who is referring patients or their clients or somebody else to our study, as long as they're not a member of the research team, they're not an individual who is going to benefit from being on a publication from the research results, and they're not actually conducting the research themselves, any research, then it's not necessary for them to submit an application to the institution or their organization to have us to be able to distribute our materials and to let the families know that this research is happening.
Right, and you have to follow, of course, your local rules, but that's from the Tri-Council Ethics Office, the Secretariat on Responsible Conduct of Research. If anybody wishes to contact us, and we can send you a copy of the actual documents from them.
Thank you. So for more information, we have a study email address, sf.neuro.study@iwk.nshealth.ca. That will reach either myself or our research assistant here, and we will respond to you as quickly as possible. We have a toll-free number that's listed there on the screen that you can call if you just want to chat about what's happening or what your needs are. If you have something that you'd like us to do, if you would like us to do a presentation for your organization, either in person or through Skype or GoTo, we can do that. We'd be happy to attend any of your local events if possible, conferences, or anything that you need us to do. We're here to make it easy for you to connect us with your families who may benefit. There's also the CRFH, Center for Research and Family Health website. We'll send out that information to you as well. It just gives some basic information about the project, about the Parent Advisory Committee, and it will also link people back to that My Studies screening and consent website. And that's it for me, I think.
We'd really like to answer any questions in the remaining time.
you very much, everyone, for a great presentation. We do have a number of questions that people have. Just a number of them came in just as you were talking about how people can get involved in the study and people just looking for some clarification. One person was asking about the age, just clarifying the age. The one slide said 3 to 14 years. Is that correct?
Yes. Yeah.
Okay. And there were a couple of questions about particular syndromes or conditions that would be included or excluded. In particular, someone was asking about Tourette's syndrome, and another was asking about FASD, if this program would be appropriate for either of those two.
Yes, absolutely. FASD definitely included, and Tourette's syndrome as well.
All right.
And ADHD is also included, but it cannot be the primary diagnosis because we have an ADHD program.
Oh, okay. All right. And someone has just asked about RAD.
I don't know what RAD is.
I wasn't sure either. So, if Michelle, if you could just clarify for us what you mean by RAD, we can certainly check that for you.
So the answer is probably yes, because we're taking, as Lucy said, a non-categorical approach. So unless if the child and the family meet other criteria, probably yes.
Okay. So she clarified it's reactive attachment disorder.
That's more of a psychiatric diagnosis. It would be, I would treat that more like ADHD. Reactive attachment disorder may be a secondary diagnosis, but not as a primary diagnosis.
I would agree with Lucy.
All right. The next question that just came in is asking how the program would work if there are more than one child with a neurodevelopmental disorder in the home.
What we would do in that situation, and this occurs all the time, is because it's difficult for parents to try and do everything, we would ask them to choose the child that we're going to focus on. But of course, the skills that they learn are going to be applicable to the other child. This is a program that teaches parents how to take control of the situation. And so we would collect data on one child rather than having them collect data on two children. And then they just have them choose which child they want to use for the designated child for the study. But the skills would be useful for all of the children involved in the family. And not only the neurodiverse kids, but the other kids as well.
The next question that's come in is asking, how does a child with autism with high anxiety and negative perseverations qualify?
Pat here. If the child is exhibiting disruptive behavior, which most children with severe anxiety do in the situation that you display, then the approach that we have found most effective is to treat the disruptive behavior first. Then in most cases, the anxiety decreases, but you can't use the classical anxiety approaches when you have the disruptive behavior present. All of the interventions, all of the approach is a very positive, supportive approach. And so consequently, it has a very positive effect on anxiety. But the child would have to have disruptive behavior as well as anxiety, even if the parent or the professionals thought that the root cause was anxiety, that would be okay.
All right. And if anyone else on our panel has anything they'd like to add as well, please don't hesitate to jump in and contribute on any of these. The next question that came in is asking if this program would work if the child demonstrates extreme defiance with his or her FASD.
Well, partially that's why we're doing the research, to see if it does work. I mean, that's why we're doing the research. But the extreme defiance is our bread and butter. And so, I would hope that it would be effective, but indeed, that's why we're conducting this research, and we'll see. But the approaches that we use and the evidence from our other programs is that, yes, it will have a positive effect. And that the other thing that it has an effect on, it has a lot of effect on the ability of the parent to control their own behavior and to control and to feel good about the parenting that they're giving.
Yeah, I think it's important to acknowledge that the acceptance of the diagnosis of FASD by the child would not be it's not a requirement. Certainly, a diagnosis of FASD and just disruptive behavior that the parents are experiencing as disruptive in a mild to moderate manner. It would, if the child fit that, then they would qualify.
If the child is a danger to themselves or others, then they would not qualify. But it all depends on what you mean by extreme. But defiance is what it's all about.
And we are just about out of time. If there are any last minute questions that are coming in, that someone's furiously typing away in the keyboard to get in before we end, then please go ahead and finish that question and send it in. But we will be wrapping up in just a minute. I did want to just share a comment that came in. I think it was during Donna's portion, and it's just been interesting listening to the presentation with talking about a research program and a research team talking about things like hope, and Donna talking about the importance of the friendliness of the team. And those aren't things you generally hear talked about from a research community. So it was really interesting to listen to some of that. But Michelle put in, she says, as someone who has recently been through the program, you can definitely feel the family perspective in the development of the program. It is very family focused, and that's one of the reasons it's so successful. So I just thought that was an interesting comment that I just wanted to share that came in.
Nice. Thank you.
And the final thing is that we will be attempting to, once the study is finished, our whole goal is to make this available across Canada through the Strongest Families Institute.
And maybe that's a good time to end. I mean, I do like to end these sessions. We don't have any other questions that have come in, but I like to end with just giving our panelists an opportunity to share any closing messages or key messages they'd like to share with the audience before they leave, where to find more information, what to expect next, anything new and exciting that's coming down the pipe that you'd like to announce before we sign off. So maybe we can just hand it over to you. We'll start with you, Pat, and if anyone else wants to join in with some closing messages, then feel free, but we'll start with you.
Yeah, the only thing that I would add is that, as Donna mentioned, we're beginning work on a program to treat PTSD-like symptoms in parents of children with neurodevelopmental disabilities or neurodiverse kids. And so that's something that you'll see coming in the next year. We're keeping on trying to do things that are helpful to families.
All right, and parents, if you're sorry, go ahead.
No, I was just going to say that I would encourage people to sign up for the through the link that you've sent out to the audience, so that we can stay in touch and provide information. There's also a newsletter. We've got quite a following coming on now. After the last year and a half, we've been working with our parents and distributing our information about the study. So the Study Recruitment Network really is the best way to keep up to date on what we're doing with recruitment and getting involved. And then the newsletter also shares other information about neurodevelopmental disabilities and keeps you in touch with us as we progress through the study, which will be the next year and a half to 2 years. So I'd love for people to sign up. I'd like to hear from you.
All right, sounds good.
Thank you.
And that, as Karen mentioned, that link to sign up for the newsletter is in the chat box there. You can just click on that. Lucy, why don't we go to you next if you have anything to close off with, and then we'll finish with Donna.
No, I think we have portrayed or communicated what we wanted to say. I really would encourage those in the audience to become involved. The success of this program is very much contingent on us receiving the referrals. And yeah, that's about it. Thank you.
All right, and Donna, any last words?
Thank you very much. I would simply say thank you all to everyone who listened in today. It's wonderful to be able to talk about this program. Hopefully, after listening to this presentation, you will all become ambassadors for for this program too, because I can tell you that all of us who are family members involved with it feel that it's going to be very hopeful and have very positive impact on families who participate in the study. So thank you very much.
All right, and thank you. Thanks to all four of you for such a great presentation and for the work you're doing. It's really such a great program, as we can see from the comments. We do have in the chat box, I think you're going to see a link appear in just a second. Our friends at ChildBright would like, if you're able to complete a post webinar survey, just to let them know how they're doing, just an evaluation to help them with the evaluation of their work. And their knowledge mobilization efforts. So please, there's the link is in there now. So go ahead and click on that. If you do have time to fill that survey out, that would be very helpful to them. And if you are watching with more than one in the group, please share it with everyone in your group there and have all of them fill it out if possible. All right, with that, I think we'll wrap it up. We do our webinars every Wednesday at 11 a.m. Eastern Time, and when you do get to watch live, as you can see, you do get to contribute your questions and comments, which really enrich the discussion. But when you can't watch live, we do record these sessions and make them available after the fact on our Knowledge Exchange Network at ken.childrenshealthcarecanada.ca. Our next webinar next week on Wednesday will be, which is January the 16th, we will be hearing from our partners at Safe Haven, who are going to be joining us to talk about advancing care innovations in the community for individuals with medical complexities. Safe Haven is one of Children's Healthcare Canada's members that provides services in the community for children with complex medical needs, and they'll be sharing some of their experiences and innovative programming in working with children and families in the community. So that will be certainly an interesting session for many of you who participated today. So thanks again for joining us today. Hopefully we'll see many of you back here next week. Bye, everyone.
Thanks, Doug. Thank you.
Thank you. Bye-bye.